the threat of privatization coming at the Veterans Administration. And we appreciate, again, your being here and doing a presentation, and then open it up for some questions, offer ideas on what folks can do, promote your book here. We'll put links in the box for folks to take a look at Wounds of War, as well as our veterans. We'll put those links in the box. And let me just say that Suzanne Gordon is an award-winning journalist and author. She's written for the New York Times, the LA Times, Washington Post, The Atlantic, The Nation, Washington Monthly, American Prospect, the Globe and Mail, and the Toronto Star, JAMA, Annals of Internal Medicine, BMJ, and others. She's the co-author of The Culture and Politics of Healthcare Work series at Cornell University Press, and is the author, as I mentioned before, of several books, most notably for purposes of today, Wounds of War, How the VA Delivers Health, Healing, and Hope to the Nation's Veterans, and more recently, our veterans. Suzanne is Assistant Adjunct Professor at UC San Francisco School of Nursing and affiliated scholar with the University of Toronto Faculty of Medicine's Wilson Center, and is Senior Policy Fellow at the Veterans Healthcare Policy Institute. Again, Suzanne, welcome.
Sure, thank you so much. So I'm a journalist and healthcare researcher, and I've been writing about health systems and healthcare delivery for, 35 years, and writing about VA care for something like 12 years. And I co-founded the Veterans Healthcare Policy Institute. In the chat, I put in the VHPI website, and I encourage you to subscribe to our newsletter and to noodle around the site. We do a lot of reports, and we are devoted to stopping the privatization of the Veterans Health Administration, and also to expanding VA healthcare to many more people than now receive it. And also we view VA healthcare as a model for healthcare reform in America. My slogan is really VA for all rather than Medicare for all, because Medicare is a payer, not a system. And increasingly, as folks realize, with the increasing corporatization and private equitization of the American healthcare system, to just focus on payment rather than delivery, I think is problematic. So I'm here to talk to you about the VA healthcare system, and I'm going to try to get you on screen, because I always start these presentations with a little quiz. It's a kind of did you know quiz. And so I want to know if, did you know that the VA develops models of care that are so the VA has 4 missions. So let me ask you, let me start with the most important, did you know? What does VA stand for? What does VA stand for? What do you think? You're muted.
Administration, right?
What?
Veterans Administration.
All right, who thinks it's Veterans Administration? Everybody raise their hand. Okay, so the very first thing you have to stop doing is saying Veterans Administration, okay? Because the Veterans Administration doesn't exist. There's no such thing. The VA, there was a Veterans Administration from 1930 to 1989, when Reagan made it a cabinet agency, and it became the Department of Veterans Affairs. Now it's logical that you would see VA and think Veterans Administration. It should really be DOV, like, Department, or it should be DOVA. But when you talk to vets, you don't want to say Veterans Administration, because then they're going to think you don't know what you're talking about, because no such thing exists. It's the Department of Veterans Affairs, and it's the second or third largest, it depends on how you calculate, largest agency in the federal government after after the Department of Defense. How many of you think that the the Department of Veterans Affairs, VA, just serves vets? I mean, its fundamental mission is to just serve veterans, right? How many think that? Okay. Well, it's actually a healthcare system that serves us all. And I'll explain why. First of all, it has 4 missions. The first mission is delivering clinical care to veterans, but in the process of delivering clinical care to veterans, the VA has developed models of care that are far superior to any in American healthcare. And if you look at the links, we have a link to studies that show that VA healthcare is actually superior to the healthcare that you and I receive, which is not saying a lot, because it's so screwed up in America. But they have developed care coordination. They developed the first and best electronic medical record in the world. They integrated primary care and mental health care. I can talk more about that later, which is a model for other systems, which can't really emulate the model because, because they have fragmented staff. They have coordinated care rather than fragmented care. They are population-based healthcare. They deal with homelessness and unemployment, economic problems, social legal problems, veterans outreach, justice program. And so, number 1, okay. Number 2, how many of you know that the VA is the hub of the American professional healthcare training system? Anybody know that? Great, thank you. So basically the VA, its second mission is teaching, and it trains the majority of American healthcare professionals, 70% of American physicians in training, medical students, nursing students, PTs, OTs. It employs 50% of the nation's psychologists, trains 1 in 5 of the nation's psychologists. And the American healthcare system, healthcare professional training program would collapse if it weren't for the VA. And let me just say that in delivering care, back to the first mission, the VA does everything that the American healthcare system doesn't. It is primary care focused. It practically invented geriatrics. It has amazing end of life care. It just does stuff that you can't get in the private sector. So teaching is the second mission. How many of you know, anybody raise your hand, that the VA is after the National Institutes of Health, the biggest research powerhouse in the nation? So any of you, thank you. Any of you have a pacemaker? Anybody has pacemaker? Okay, Don, you should thank the VA, right? Nicotine patch, first shingles vaccine, barcoding. I mean, you name it, they did it. And it's, the prostate cancer, American Prostate Cancer Foundation in 2016 established a research collaborative with the VA to answer sort of vexing questions in prostate cancer research. Why? Why? Because the VA has the largest collection of prostates, in America from discharge to grave, right? The reason why the VA is such a big powerhouse is it has the largest stable patient population of any health system in America. I hate to use the word system and when I talk about the non-VA health arrangement or non-systems, because it makes it sound like there is a system. But, to collect big data, you need stable patient population, and they have it, right? It's interesting because one of the other research questions that only the VA can answer is, about medication side effects. Why? because the VA prescribes the drugs, so it knows what drug Joe Smith is getting, right? It knows they pay for the prescription, so they know whether Joe, filled the prescription, whether he renewed the prescription, and they know the side effects that Joe had because he took the drug. And nobody else really can answer those kinds of questions. I think they publish like 9,000, literally articles a year. We have, I'm working on some fact sheets that I can send you all about VA research. And finally, has anybody on this call, and I will send you one of my books if you have. Does anybody on this call, hasn't anybody of this call heard about the VA's fourth mission? This is good. I do these talks and in person, I always say, anybody who answers one question, right, I'll give them a book, and I almost never give any a good book. And, with all due respect, I mean, it's sort of extraordinary that some of the most progressive healthcare reformers in the country know so little about America's socialized medical system. We can talk about that. I mean, there's a very good reason for that. They don't want you to know about it, right? I mean, they stopped, once it became a great system in the 90s and Bush came in and, Business Week and Harvard Business Review and Forbes were doing all these stories about what a great healthcare system the VA was and how it was a model for American healthcare. And this is true. They really thought that, the market addicts thought this is really bad. We can't have a narrative out there, a factual narrative that, a government run system is good. And so they started shutting down VA communications. So VA cannot communicate this stuff to you. It's pretty extraordinary. I'm like their public relations firm. It's kind of a joke, Anyway, the fourth mission, which zero people know about, and I didn't know about any of this stuff either. I've been struggling in the vineyards of healthcare reform. I had no idea that we had a system around the corner that was this amazing. And the fourth mission is to serve as a backup for the rest of American healthcare in times of war, conflict, terrorism, or national, regional, or local emergencies. So every time there's a wildfire in California, the VA sets up a, wherever it is, if it's in, Northern California and San Francisco, VA sets up a command center. They call every patient that lives in the affected area. Do you have your meds? Do you have your this? Do you have your that? And affected others can also come to the VA and get help. In Hurricane Maria, the VA hospital in Puerto Rico was the only functioning hospital on the island, and it took all comers, And I mean, I don't know about you, who lives in California? Anybody live in California? All right, have you ever gotten a phone call during a wildfire? Did you ever get a phone call from your doctor or your healthcare system saying, hey, Don, how you doing? Can you get to your appointment? I mean, really? I mean, it's incredible. And for example, VA really pulled its fourth mission out in COVID. They basically made available, every VA ICU was made available for non-VA patients during that emergency. In many places they didn't, like San Francisco, they didn't use them. They sent staff to hotspots around the country. In New York, Louisiana, New Jersey, they welcomed non-VA patients into their ICUs when hospitals were overwhelmed. They took over state veterans homes that were run by horrible for-profit companies in places like North Carolina. And it was quite interesting because VA, because it has, a global budget, right? It's not fee for service. So they immediately started canceling elective procedures and in-person visits, while hospitals across the street were continuing them because, VA doesn't lose any revenue. And because VA docs are on salary, some orthopod who isn't doing knee replacements anymore, they could say, sorry, Joe, you're doing COVID testing now, and nobody objected. We have various things on our website at Veterans Healthcare Policy Institute about this. You have a healthcare system really that, from the point of view of healthcare reformers, oh, and excuse me, I need to say one more thing. In regards to health equity and disparities in health, the VA is like really serious about this. I mean, all these other hospital systems, have, UCSF, a big Office of Health Equity, UCSF has one social worker in its primary care clinics for 28,000 patients. One social worker. The VA has social workers in every single primary care clinic. Well, that's telling you something, right? We don't want low income, complex people of color patients with problems, social, and economic, socioeconomic problems. And we're going to signal to them not to come here by not having any help for them. Whereas the VA has, psychiatric nurse practitioners, psychologists, dietitians, social workers, pharmacists in every primary care clinic. I once had the temerity to ask a urologist how to take my meds, and he got really pissed at me because I was slowing down the assembly line. In the VA, I would have been taken to see a pharmacist who would have spent 45 minutes with me to help me figure out how to take my meds, And it turned out I was taking them wrong and got a UTI. Complication, post-surgical complication. Anyway, and in COVID, for example, there were no healthcare disparities in patients' deaths for people of color in the VA. There were more people of color had COVID, but not more people have died. And several studies have shown, for example, that African-American patients with certain kind of kidney problems, because they have access to care in the VA, actually do better with certain cardiac problems, all of which is Greek to me because I'm not a doctor, a nurse practitioner, or a PA. They have better mortality and outcomes than actually white people in the VA. So when you're looking at access, wait times, quality, affordability, and equity, which is what we want in a healthcare system, there is no other healthcare system in the United States. Well, there is no other healthcare system in the United States, but excuse me, there's no other healthcare system in the United States that delivers like the VA does. And it's here, it's around the corner, it's down the block. It's not in Canada or Taiwan or the Netherlands or Scandinavia or, France or the UK. Every physician, every employee in the VA is on salary. And it delivers better health outcomes. It's great. It's a great system. I wish I could get VA care. There was just a study by 3 economists at Stanford who did a study on a kind of random controlled study on vets who are duly eligible with Medicare and VA, and they were basically 500,000 of them were taken in ambulances to either randomly, pretty quasi-randomly, to a VA ER or private sector ER. The ones that were taken to the private sector ER were twice as likely to die in the first 28 days than the ones taken to the VA ERs. It cost 21% more for them to be twice as likely to die. And I read that study and I thought, why are they taking me to a private sector ER? And the reason that they do better is because they get better follow-up. And we have a discussion of what happens to a vet during an emergency visit to an ER on our blog on Veterans Healthcare Policy Institute. But, you know, I mean, it's very interesting because one of the ways that they're trying to privatize the VA is to outsource more patients to the private sector. In 2018, they passed something called the VA Mission Act, and they set up something called the Veterans Healthcare and the Veterans Community Care Program. It's fascinating the way they use language. The Veterans Community Care Program, VCCP, as if, you know, private sector providers were somehow, you know, this warm and fuzzy community, and the VA is somehow callous and cold-hearted and not part of the community. And it really should be called the Veterans Corporate Care Program. And we now have 8 million appointments, and over 35% of the VA's clinical care budget is being siphoned off to private sector providers who are not required to know anything about military cultural competency or veterans' complex healthcare problems. And veterans are different patients, you know. They have twice as many comorbidities as non-veteran patients. They have 50% of them have some sort of serious mental health diagnosis. They have more chronic pain. They have higher rates of suicide. They have military sexual trauma, et cetera, et cetera. They have higher rates of schizophrenia and bipolar disorder. Why? Because schizophrenia and bipolar disorder appear when in your late teens and early 20s, just at the time when you go into the military, right? They have higher rates of homelessness, legal problems, et cetera. And the other thing that you need to know about the VA, how many of you think that, and let me point out that I'm not asking these questions of you, you know, to show anybody up. I never knew any of this stuff before I started writing about the VA. You know, I had the same assumptions and the same amount of ignorance that everybody in America has about this healthcare system that we all fund, right? It was news to me. When I went in, I thought, when I started writing about VA healthcare, I thought every vet is covered, right? Don't you think every vet is covered? And you served in the military, you get VA healthcare. How many of you think that's true? Not true. Basically, you have to have a proven service-connected disability and or low income. So this is pretty interesting for us, right? The VA takes care of the oldest, sickest, poorest patient in America. It cherry picks people who are old, well, who are poor and sick, and then they get old, right? And because they stay in the system, so they remain in the system as they age. And they still deliver better outcomes at lower cost to more difficult patients. I mean, and have any of you worked in the VA recently? Veterans are very difficult patients. I mean, grumpy, suicidal. And there's a cohort, sub-cohort, small, tiny, that are actually a danger to themselves and to their care providers. I mean, the most interesting thing to me about what I learned about the VA is, anybody here a doctor or a nurse or anybody? Don, you are, okay. You have a, you know, when you worked in the hospital, you have a lanyard, right? Or the clinic, you have a lanyard where your badge is on, right? And your lanyard or whatever you call it is usually a continuous strip, right? A continuous strip of cloth or whatever. In the VA, there's a little clip at the back of your lanyard because some of these vets can be a little scary and try to strangle you with your lanyard. And if they pull on it, it opens up. That tells you something about the patient population. They have special programs for so-called disruptive vets. I mean, this is a real stereotype, but it's a stereotype that has some truth in it. I mean, the vast majority of the shooting incidents in America have been done by vets. You know why? Because like they have problems when they go into the military. The military adds to those problems and teaches them how to use guns and other things, and then they come out and we don't really take care of them very well. So this is a really amazing system. And the point I was trying to make here, which is interesting, I think, is that although Congress didn't intend this, when the majority of Democrats and all the Republicans voted for the VA Mission Act, which sets up this privatizing program, they didn't intend this, but they set up a sort of gold standard random control trial between the VA and the private sector, because they started sending millions of vets to private sector providers. And guess who won the random control trial? The VA, even though it was deprived of 35% of its budget. I mean, it's incredible. And so we have a healthcare system, and my argument to healthcare reform activists is it's really important to know about this system, because we know more, most of us know more about, I certainly did, Canada or the NHS or, you know, the Netherlands or wherever, than we know about the place around the corner or across the bay, you know, in my case in San Francisco. And they are trying to cripple this system and deprive us of a homegrown model of care that we can advocate for. And they use the VA, they try to destroy the VA, and then they tell lies about the VA, right? Ignoring the facts. I mean, of course the VA has problems. I mean, how could the largest healthcare system in a country not have a problem? You know what I mean? Of course it has problems, but it's also the most accountable healthcare system in the country. So we know about these problems. Every single thing you read about the VA, you could read about another healthcare system, except, you know, somebody sues, you know, Sutter or Harvard or whatever, or, you know, Brigham and Women's, and it's a non-disclosure agreement and you never learn about it. In the VA, you have Congress, you have the VA Office of Inspector General, the Government Accountability Office, the media, the Koch brothers, you know, everybody, the veteran service organizations, everybody is on their case. And I'm not arguing that they shouldn't be. And, you know, and so really why I want to talk to healthcare reform activists is I think we need to know more about the VA. I think you need to know more about the VA for positive reasons, which is that it's an incredible system, you know. Providers are mission driven, not profit driven. The patient panels are smaller, although they are trying to change all this, right? They're trying to destroy the system by depriving it of funds and also by importing private sector practices into the VA. But we need to protect the system, we need to expand the system, and we need to be able to rebut the right-wing attacks on the system, all of which are, every single one of which is easily rebuttable. And so I think that it's really important for folks like you to know about it. And also, I think it's really important for people to understand, which is where I began, that this is a system that serves us all. It's not just for veterans. Because if we conceptualize the VA as a sort of charity for 1% of the population, you know, it's kind of like the beggar on the street, right? It's thank you for your service. You're screwed, you know, and the Republicans are actively, as we speak, trying to kill the system. And tragically, they have many corporate Dems on their side, right? Because, you know, the tragedy is that I could be giving the same talk to staffers on the Hill, and they would not know anything about anything I'm talking about, you know, because they don't have much information about the VA either. So I'm going to stop because we only have a few minutes left. I'm sorry I got on late, and but I would love to answer your questions, strategize. I mean, I think it's very worthwhile thinking about, okay, you decide your slogan is VA for all. What does that mean? Because it certainly doesn't mean that tomorrow 330 million people descend on 170 hospitals and 1,200 sites of care. That's not what it means. So I'd like to close and respond to your questions.
Terrific. Suzanne, that was extremely enlightening. I learned a lot. I think Most of us did. This has been a bit of a blind spot in the healthcare justice movement. We want to call it that. And I do share your concern about the terminology single payer. I've always had difficulty with that because it does just seem to underscore funding as opposed to funding and delivery. So it's important that we join the two in conversation and understand how they interface. So thank you for that.
And I want to give a shout out to Don and others who have begun to, really talk more about moving from a sort of, Medicare for all to a national health system model and talk about the VA. Thank you. I should have done that in the very beginning of the talk.
We still have a good 15 minutes or so we're good. So up the hands that are up right now, we got Peter and then Cheryl. Peter, are you muted? Yeah, you need to unmute, right?
Okay, okay, there we go. Suzanne, that was terrific. Thank you very much. And I think it really calls for kind of a radical rethinking on all of our parts. What interests me is there's a big debate going on right now in the single payer movement about whether HMOs have a proper place in a single payer system, or whether they're basically just a way of practicing exclusionary discriminatory care. And a lot of the things that HMOs use to justify themselves, like an emphasis on primary care, so you don't have to go back to the doctor when it's too late, or coordinated care or integrated delivery. To some folks, these are like dirty words because they're basically euphemisms for cost cutting, and getting rid of the more difficult cases and stuff like that. Actually, I don't want to get caught in that trap, and I don't want to fall on my sword in defense of fee for service either, because any payment system can be corrupted if the profit motive is involved. So I just wanted to throw that out. It's not really a question, I realize, but I do think we need to rethink it, especially given what's happening to Medicare right now.
Yeah, well, I mean, the VA is not fee for service, and I think you saw this during COVID. I mean, there are people in the single payer or healthcare reform movement who think, oh well, the VA should just be sort of absorbed into. If we waved a magic wand tomorrow and had our dream system, the VA would disappear. That, please do not ever make that argument, particularly to veterans. Really, then you're gonna, I think that as long as we have an imperial military with a, vast amount of people, I mean, not vast, but 1%, 10% of the 1 to 7% of our population and more because of the families, right, who suffer from these problems. I view the VA as a sort of population-based system, like, I don't know, pediatric, you know what I mean? But there's lots of ways to talk about how we could expand the VA's model of care to broader people.
Okay, thank you, Suzanne. Peter, for the question. Cheryl, you want to unmute?
Yes, thank you. It was wonderful. I learned a lot. I think maybe I might have met you. We're both friends of Barry Thorne in Brandeis in the graduate school days or something. Are you the Suzanne Gordon? Okay. Different one then. Do you, if you are low income, do you go through an intermediary, or can you just walk in the door if you want veterans care and you are otherwise affiliated?
Right.
I'd love to know how it did with Katrina. That's pretty detailed and practical, so you don't have to answer that, but I'm interested, and maybe I could find out somewhere. I want to learn more about this. Thank you.
So basically, the Department of Veterans Affairs, VA runs 4 sub-agencies. The Veterans Health Administration, VHA, which is the healthcare system, the Veterans Benefits Administration, which is the largest benefits enterprise in the country, which oversees the GI Bill and home loans and compensation and pension for veterans, et cetera. In order, if you're not an Iraq or post 9/11 combat vet where you get 10 years now free care, if you served in a combat zone, you have to go to the Veterans Benefits Administration, to prove the income requirement or the service-connected disability requirement. This eligibility stuff is very important and very complicated. And there's the military has a category of discharge. Your eligibility for VA care depends on your discharge status. So if you have if you have a dishonorable or bad conduct discharge, which you have to have a court martial. If you have what's called an other than honorable discharge, which is a category of discharge that is used really to punish people who have traumatic brain injury, PTSD, who report a military sexual trauma, et cetera, you can be denied care and benefits forever. It's absolutely disgusting. The military uses it. We describe it in our veterans and every healthcare reform activist to show that they support veterans. And I don't care what you think of these wars. I've been on the front lines of fighting them since I was 18 years old. But we owe these people, care and benefits, particularly since we have an all-volunteer army. And this OTH discharge is really disgusting, and the military has to stop using it. Good luck for that. The military, I have to tell you, would fight like hell against, we have not presented a serious challenge, whether you call us single payer healthcare reform advocates, but you give people in America free healthcare, and the military is going to come down, and you get serious and become a formidable force. And let me tell you, they're going to come down on you like you won't believe, because the two recruitment tools they have for the all-volunteer army is free education and free healthcare. People are not signing up because they want to go fight the jarheads. I'm sorry, please forgive me, that language, but they are not fighting because they want to get the bad guys. They are signing up, and they would have to bring back the draft if we had free education and free healthcare in this country.
Thank you.
Thanks, Suzanne, and thanks, Cheryl, for your question. Mike Huntington?
Yeah, Suzanne, regarding the other than honorable discharge, I just got a long letter from a lady here in Corvallis who has had a series of long setbacks, student loan payback, but her husband also has a series of health problems. He is in that category, other than honorable discharge. Are there any appeal routes for that? And the other question is, I don't know if you had heard about the talk given by Professor Greenwood at the Berkeley conference in 2020, just before the pandemic, about offering a Medicare for all and a VA for all as a choice to the entire population. Any thoughts on either of those?
Well, the OTH, there have been petitions to the VA to change the VA's. We could do a whole thing on OTH. If you go to the Swords to Plowshares website, I'll put this in. There's a rule. I'm not good at talking,
Take your time, Suzanne. It's okay.
There's a petition for rulemaking change to the VA. It's very complicated, and I can be glad to, tell people more about it offline. But the VA, has not acted well on this. And, tragically, the veteran service organizations most of them are opposed to it, because the big service organizations also won't you can't be a member of the Legion or the Disabled American Veterans of the VFW or a whole bunch of, if you have an OTH discharge. I think we have to have a very serious discussion of what VA for all means. I can't tell you off the top of my head, Medicare for all, you can choose one or the other. I don't think that's going to work. You know, how do you plan a system if you don't know what your patient population is? If you're like, well, one day Don could come here and the next day Don could go there. And, you know, how do you staff? How do you budget? I mean, I think personally that we should think about different ways to get to VA for all. One way is to allow all veterans into the VA, right, and staff up and fund up for that. I would favor all veterans and their families, because, you know, now we have 9 million, you'd have 19 million veterans, and then you'd have conservatively 40 to 60 million more people if you counted their dependents, maybe even more. That's a whole lot of people experiencing socialized medicine. And then if you allowed community people into underutilized VAs, they're doing this. For example, White River Junction in Vermont is providing mental health to non-veterans because of crises in mental health care in rural Vermont. So there are ways to get there. I think you should have pilot programs where you let people, you know, into the VA who are, you know, people like me. I mean, let VA caregivers who aren't veterans get care at their own bloody healthcare system, you know? I mean, can you imagine Kaiser saying to Kaiser employees, sorry, you know, you can work here, you can develop models of care, but you can't get your care here. Well, unless you're a veteran with low income and proven service-connected disability. I mean, here's a great story. I don't know if you know, any of you know who Ken Kaiser is. He's like, you know, a hero in the firmament of patient safety. And he's the one who transformed the VA in the really broken VA pre-1990 into the great VA we have today. Ken, who's a veteran, can't get care at the VA because he has too high an income. I mean, what a joke, you know? Ken, who developed the system. It's ridiculous. Don, I think you had a question.
Yes, excuse my communication. I had a series of strokes and actually was in coma for terminal care. But I've recovered pretty well, but not completely. So I have some communication problems. But I wanted to mention that the privatization problem that, you know, the VA is undergoing that right now. And of course, Medicare, today's our health justice monitor today that I wrote is A.D. Barkin mentions the great news about the new legislation before Congress of Medicare for all. But his article in Nation is titled "How Medicare Advantage Could Kill Medicare," and that's the privatization issue. And I've been meeting with some of the icons in PNHP, and we're very concerned about the fact that, quotes, single payer alone will not do it, that we're going to have to do something about this privatization problem. And you know, we keep looking at the VA. We're going to have the community involved, and we think the VA provides a much better model for healthcare. And you know, I'm going to be gone, so I'm not going to be around to you know, I'm 85 now and on my way out the door, but I really want to get the healthcare movement moving in that direction where we can get real healthcare for the entire nation. And anyway, I just had to say my piece there.
You're so right. And, you know, I think we have to form some kind of broader committee to talk about what this really means.
Absolutely.
You know, let's just say everybody in single payer said, okay, it's not Medicare for all, it's VA for all. Well, what does that mean? you have to think that through, because I think it means two things, well, probably more, and I haven't really begun the thinking. And Don, I'd love to chat with you and others, but I think it means, and by the way, Don, it is the same people, the same exact groups that are trying to privatize Medicare, that are trying to kill the VA and the NHS.
That's right.
These people we are like spending all our time defending and not like, on the offensive, like, which is my argument with folks in the VA. What do we want the VA to look like? Stop, as opposed to, stop doing the bad things. Well, what is our vision? And I think that, VA for all means two things. It means expanding the VA, saving the VA, improving the VA, allowing more people into the VA. And it means, creating a system, a VA-like system out of the rest of it.
Yeah.
Because that model, right? And that model is very granular, right?
Right.
We have to look very granularly. End of life care, primary care, geriatric care, home-based primary care, blah, 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 homeless.
You really need to be part of the team.
Pardon me?
You need to be part of the team that's going to put healthcare together again for America.
Thank you. Well, we should, we should all talk offline, but you have my email, Don, and I'll put my phone number in here. Again, I have a hard time. I don't know, maybe it's because I'm, we're all on our way out, obviously, but I'm like you, I said, sooner rather than later, right? Wouldn't it be nice if we got some glimmer of hope before we go?
Yeah.
Ruth, I think you raised your hand.
Yes, I just wanted to mention, I didn't recognize really that there are only 3 countries in the world, I understand, that don't have health care for all their people. And when people hear that, they're shocked to hear that. Why don't we broadcast that? Why don't we say that all these other countries in the world take care of their people and provide health care?
Well, I think that's pretty well. I think people who know that, but I think that you're raising a broader question, in my view, Ruth, which is we have to get way better at our public communication strategies. And I think, that's a whole other conversation.
Thomas Gottlieb has his hand up.
Yes, thank you so much for this wonderful presentation. You're making a great case for what we call socialized medicine,
Right.
and the outcomes that are designed either by the Brits or by the VA system are really outpace those of any other financial system. So that's the case that I'm taking from you, and I'm trying to match that with the work we do for building financial models. For example, a financial model for Medicare and Medicare for all, in which the insurance, if we have an insurance model rather than a model for socialized medicine, the actuarial science is what is used, and it's very accurate for healthcare delivery, but is very inaccurate for delivery and financing the delivery of social determinants of health. And I'm pleased that socialized medicine solves that problem. So how do we go about solving that within America? And there are several models that can be used. Socialized medicine is one. Working together with Medicaid, which covers both social determinants in addition to healthcare delivery, and yet many other models. And I'm just wondering, do you have a notion as to what you prefer for us in America?
So this is a much longer conversation, and I actually have to go because I have a 10 o'clock. I just think what this conversation suggests is that there are many, many questions, one of which is your question. And I I can't answer it in 2 minutes. And I just think we need to figure out where do we go from here, you know? I mean, what do folks think about this presentation? What about people think about this idea? I am for socialized medicine. I think the country is, you know, kind of ready for it. I think docs who are now, you know, just kind of cogs, nurses, like, you know, are ready for it. And we can, I mean, you know, and the reality is, even if we don't want socialized medicine and don't argue for it, they're going to say, the right wing is going to say that we do want it. So what the hell, you know?
Yeah.
I am so sorry, but I have to go.
Thank you.
And I would love to continue this conversation and invite me back or whatever, or set up a committee and I'll be on it. And Don, let's talk. And thank you so much. Please forgive me for getting off abruptly.
Thank you. Thank you,
Thank you.
Suzanne. Appreciate you. And yeah, let's keep that conversation going. You take care. And folks who are still with us, thanks everybody for being with us today. And the work that we're doing at One Payer States does need support. Whatever folks can contribute, donate. We're always looking for fresh blood, volunteers, covering all these questions, you know, around policy, outreach. We need to find a champion or 2 or 10 or 100 in Congress to actually take up this conversation. We have to figure this out. And just by a very quick way of update, I'm going to be meeting with Congressman Ro Khanna this coming Thursday to be talking about how we're going to roll out the state-based universal healthcare legislation that he's been carrying for the last few years. Prior to that, it was Pramila Jayapal and so forth. So just want you to know that we're making tremendous progress, but we do need support. And thank you so much for being with us today. Thank you. Thank you. Peter, your hand is up.
I'm just hoping that we can come back to this discussion, you know, and go into it in greater depth, because I think there's some real strategic issues raised by it,
Okay.
perhaps the surface of today.
Yeah, let's have a conversation, you know, within One Payer States, folks, and then figure out what that looks like going forward. Okay, thank you again, Dawn and Peter, David, Ruth, Jan, Elaine, Cheryl, David. Thank you all so much for being with us. If I didn't catch anybody, Mike, thanks for setting this up. Thank you, everybody. Tom, Barbara. I know I'm missing people, but in any case. Spirits there, Lode, thank you again. I'll give you a holler later on, Lode. Thank you so much, everybody.
Thank
Mike.
you.
Mike, you want to stop the recording?